Hello, everybody. Welcome to JBI Live for August 2024. My name is Craig Lockwood, and I'm really pleased to be speaking with you around some really interesting and important topics today with a colleague of mine, Dr. Lucylynn Lizarondo. We're going to be addressing some of the strategic and fundamental issues around clinical leadership, how that intersects with governance, but taking a really different perspective, because I think we've all done clinical leadership work in the past and understand the nature and context of it. So what we want to think about today and bring to you as ideas and things for conversation is thinking about the relationship between some of those governance and leadership issues that we care about and the way they articulate into pragmatic daily activity. And maybe it could be summed up by saying, you know, when we lead people. When we manage programs. And how do you bring them together? Well, you take programmatic kinds of approaches to dealing with the integration of evidence into clinical decision-making, policy and practice, of course. So I'd like to start by introducing myself. I'm the Program Director and Executive Deputy Director for JBI, based in Adelaide, Australia. I'm a registered nurse, and I love this space, this work, this area of implementation. But if I like it, then my colleague, Dr. Lucylynn, is even far more steeped in it. So Lucy, would you like to introduce yourself?
Thank you, Craig. So I'm a physiotherapist by background, but I've always been a health services researcher, and my area of research interest is really around improving the quality and safety of healthcare services. Hence, I'm joining Craig in this JBI Live today.
Awesome. Thank you so much, Lucy. And thank you to everyone who's joined us here today. A little bit of housekeeping, just so that we all get the best value out of it. You can interact via chat. There is a Q&A, which we'd love you to use. We chose to put the word conversation on the title screen. So feel free to raise questions or ideas and discussion with us at any point that you prefer. We, of course, will make a recording available to you afterwards. And because of the era that we live in, you might want to also take screenshots or use social media. If you do, we'd love to see and hear about that and make some noise with you. So please, if you're tweeting, use hashtag JBI Live, and feel free, of course, to add an at JBI EBHC to any of your tweets. Right, that would be really awesome. That's a great thing. I'd also like to, of course, pay my personal respects on behalf of Lucy and myself to the Kaurna people, the traditional custodians on whose lands we are gathering today, and acknowledge the deep feeling of attachment and relationship of the Kaurna people to country, and acknowledge our respect to them and the value of their past, present and ongoing connection to land and cultural beliefs. So this is going to be a talk in 3 parts, and I hope you're okay with that. So I'm going to take us through the first part, which really is scene setting, laying the groundwork. And I'm hoping and I expect a lot of this will be familiar to you already, because we're going to be talking a bit about some of the challenges rather than just rolling with the assumptions that evidence-based practice or EBHC delivers what we need. We're going to look at some of the challenges that have led us to this point in time where we're really looking to revitalize and take a very different approach, a very structured, strategic approach to corporate and organizational change processes. And the reason I want to start this way is because of a quote that you can see on screen, where there's long been recognition that health is why we're all here. Human health is a thing we all have in common, whether we're academic, whether we're clinical, managerial, but really establishing and maintaining a vital and viable link between health and academia, or if you like, health and research, has always been a little bit tenuous, a little bit difficult to manage. And so my job is to take you on a bit of a whirlwind tour, really based on looking at a couple of key papers that have come out over time that really encapsulated some of the challenges and problems with health at times in the past. So this is from key discourse papers that have really changed. It says EBM, but you and I know we mean evidence-based healthcare. So the very famous Doug Altman wrote this paper about the scandal of poor medical research. We could easily say the scandal of poor health sciences research, couldn't we? And the summation of his argument was that a lot of research that's conducted uses the wrong methods or the wrong techniques, or it uses the right techniques but inappropriately, or the sampling framework has been problematic, or the analytic process that was chosen was a poor fit for the work that's been published. And sampling, selective sampling, biased allocations, misinterpreted results, selective reporting, selected citing, and unsupported conclusions. This paper, published in 1994, has never been more relevant and true today, has it, when we think about some of those challenges. So back then, Doug Altman said, actually, we need, because he was thinking about research and its real true potential to apply to practice. So he said, we actually need less research, but better research, and research that's done for the right reasons. In other words, he was thinking about that relationship between research and its intended use and impact, not just, I need to publish something. So that was an acknowledgement that research needed to improve. And then along came David Sackett in 1996 and said, not only do we need better research, we need to define how and where we apply it. So he defined evidence-based medicine by saying it's, and listen to these words, these are measurable terms, the conscientious, explicit, and judicious use of current best evidence in decision-making about the care of individual patients. So those are really good ways of thinking about that and trying to define and increase the utility of moving from research to evidence to inform thinking about. And then, of course, we launched very much into the era of guidelines, because guidelines were going to solve many, many things for us. This is a 2-year-long study that found that when you give people access to guidelines, most people don't use them. In fact, what they specifically found is that individuals do not go through the steps that are traditionally associated with a rational model of evidence-based healthcare. In over 2 years, the research team stated not once in the whole time we were observing them, nor while we observed them indirectly, did they read the guidelines available to them in paper or electronic form. So we've gone from the problem of research to the need to define evidence-based practice to articulate in better action research to, we then moved into a guideline era, but the evidence for guideline uptake and strengthening of clinical practice is actually really poor. It's quite weak. And other research, Jeremy Grimshaw has said that to implement a recommendation from a guideline requires a minimum of 2 years of concerted effort, and it might not be a sustainable change. So clearly things need to be different. We actually need a fresh perspective, which is what we want to talk about today. A fresh perspective based on a strengthened and close pragmatic relationship between academic, clinical services, so that we speak the same language and we do the same things, and we provide and ensure that the evidence pipeline coming into health services is really relevant to the clinical needs at the point of care. And why would that be an issue? Well, for nursing, it's an issue because we just don't have the privilege of having as many randomized controlled trials, and nor do our questions always fit that randomized controlled trial model. We're interested in, sure, measuring things like how big is the problem, but we're also interested in what are the root causes of problems. And often the root cause is a human health issue that can't be measured in an experimental trial. And then how does a patient feel, either about this intervention or about this style of communication or this approach to clinical care? So we have a vast number of questions that don't perfectly suit implementation if our conceptualization of implementation is research, so randomized controlled trials, through a pipeline of guidelines or some other mechanism, and then into clinical practice. That doesn't fit an organizational care model. And nursing is generally structured around cohorts of staff working to an organizational care model. So how do we then embrace and adapt knowledge and help move knowledge from clinical decision-making into action? Well, I've been hinting already, but you already know this as well, so I won't labor the point. Knowledge is necessary as a guarantor of action. So in the same way that a lot of guidelines, because we give people a guideline and think that we've done the right thing, in fact, is to integrate multiple strategies at development of leadership, creation of the fact that human behavior is important. And that ethnographic study sort of speaks to the fact there are no rational actors in healthcare delivery, right? Actually getting a coordinated, cohesive approach can be quite a challenge. And to make it viable for professions like nursing and the allied health team that are the largest by volume workforce, we actually need change processes that are just not built around randomized control. We need change processes that are accessible, that are low cost, of clinical practice are sustainable. So these are important characteristics for us thinking about going forward. Now, together today is to think about using, and it could actually look like. So we're going to talk about this particular model, but you can back out that as to talk about the role of models, the role of methods and why methods are useful, and mechanisms of action that then unpack and give those engagement and sustainability across organizations. So that sounds pretty exciting, doesn't it? And it's all sort of inspired by thinking tools reliably into care processes that are practical and useful. That question on face value, we have to reject the assumption that if we give people access to evidence, then everybody will be on board and it will be straightforward. Instead, what we need is a strong commitment to implementing recommendations, and that can take quite some period of time. Hard questions of routine care is the first step that we need to think about in terms of innovation and innovation in practice. Why a model then? And I think it's a really good question, and we should challenge the assumption. But a model gives us the ability to framework in our methods well and clearly to an audience. And then, of course, that has a model and that uses one. In which case, I would just suggest models are a typology. Work with what is useful, comes to determine what's useful, and be prepared to swap. Models can be particularly useful when they're paired with an implementation framework. And if yours is not pairing well with an implementation framework, then consider moving along from it. Models also address a number of challenges that I would argue they're not completely unique to nursing, but they're important in nursing. So this is the vertical text that I'm going to speak to here, partly about health system sustainability, and that's important in nursing and allied health because system-level workforces, such as nursing and allied health, are often seen as a cost center rather than as an organizational asset. So we need to move that thinking. In terms of evolving evidence, that's also a challenge for us with how do we stay up to date and keep the access going. And uncertainty, and how do we deal with uncertainty in clinical context. So let's have just a little look at some of the things we can do here. We can improve sustainability even in open systems like healthcare by including closed loop processes. So all of the systems we work in are open. External variables and events play a really significant role in explaining what's happening within a healthcare organisation. You might have seen the news, Australia's running low, very low on intravenous normal saline. Why? Because external variables influence our healthcare system. In fact, that's always true in healthcare. We have state and federal inputs, we have local communities, we have governance and operations. Yet the more open systems we have, the higher our risk of variability and vulnerability. So the means for compensating for an open system is to have closed loop processes. And we need those in clinical practice in particular, practiced by cohorts of trained staff to avoid critical incidents and adverse patient outcomes. That comes from cohort-based training. It doesn't really come from our post and undergraduate training models at the moment. It really comes from specialist cohort-based training. And if we have those things, then we have the capacity to integrate quality improvement-based learning initiatives through the education and training and into the point of care and the way we manage quality. So we're not saying that access to evidence at the point of care is irrelevant. It's still important and critical for clinicians to have access to evidence at the point of care. And this is part of the JBI suite of resources that help with evidence-informed decision-making. You can get access to new evidence, access to regularly updated evidence, and avoid the risk of siloed clinical practice by having a standardized toolkit available for staff. That can help us address clinical uncertainty because when we have access to standardized evidence-based resources as part of our practice domain, we can decrease inappropriate or inadvertent variation, address gaps, and the cumulative effect on uncertainty is actually that it creates this risk of mismatched or incorrect decision-making and resistance to change. So if we can compensate for that by bringing in the right toolkit, we're well on the way to dealing with the issues that are at hand. So, Lucy, what do you think? That wasn't a very good transition, was
it? Thanks, Craig. That's a good segue. So Craig has just spoken to us about the importance of having a model or a theoretical framework and having to have closed loop systems that would help address the uncertainties in an open system, which is inherent in a health service setting. So going back to the 3 M's that he mentioned earlier, we now move on to the second M, which are the methods. So the second component of the 3 M's are the methods. So when we talk about methods, these are specific tools or techniques or processes that can help health professionals or clinicians, if you like, to carry out implementation work or improvements in clinical practice. Now, he mentioned about the use of, one of these methods is the use of cohort-based training. And Craig mentioned earlier the importance of having group of practitioners to be trained. So you have a mass or a group of people. So that's cohort-based approach to training, and also the importance of having programmatic implementation methods to ensure that research is then systematically translated in health services. Now, what do we mean by this cohort-based approach? So because it's a cohort-based approach, you would think that it would promote collaboration. But not only that, with a cohort-based approach to training, you're also providing hands-on experiential learning in a clinical environment. So by moving through that process as a cohort, the participants can then learn from each other. They can engage in problem solving and then apply what they've actually learned to real-world clinical practice settings. So that cohort-based approach fosters strong collaboration, and it also ensures that evidence-based practices are not just learned, but they're actually applied in clinical settings. So they learn not just through traditional education, but by actively engaging in evidence implementation projects, or I like to call them programs, within their workplaces, and then they get support from expert facilitators, and then of course they've got their peer cohorts. So the goal there is to ensure that the evidence is not just learned, but it's effectively put into practice to improve health outcomes. I also mentioned about programmatic approach to implementation or to improving clinical practice. With programmatic implementation, what we mean by that is that you have a systematic and an ongoing process of implementing evidence into practice. I know I said evidence implementation project, but with a programmatic implementation, you're making sure that it's not a one-off intervention, that whatever changes you introduce in clinical practice actually becomes part of the standard operating procedures within healthcare services. So when you think about evidence implementation for quality improvement, this has to be embedded within the healthcare service. It's not meant to be just a one-off intervention and that's it. So it needs to have continuous feedback loops, some adjustments, and then you scale up successful interventions. So the importance here, we're highlighting the importance of having cohort-based training programs for implementation, as well as a programmatic approach to implementation. Now, aside from those, it's also important to have a tool that can assist health professionals in operationalizing what Craig mentioned earlier about the importance of having a model or a framework that then aligns with real-world clinical settings. So a tool that can help ensure that those theoretical models and frameworks, whatever they are actually translated into actionable steps. Now, that operationalization is very important because we want to ensure that the relationship between research or evidence and health services is not just purely theoretical. We want them to have tangible outcomes in patient care. So an important, in the slide, you can see here, I've given an example of a software tool that's been designed to assist healthcare professionals in implementing evidence-based practices within clinical settings. Now, this software tool allows clinicians to create an action plan and then guides them through the process of creating actionable implementation plans for integrating research into practice. Now, that includes identifying areas where obviously change is needed or improvements are needed, and then mapping out the different steps required to implement those changes. Now, this basis here, which is practical application of clinical evidence system, it supports the continuous monitoring and evaluation of clinical practices by allowing users to conduct audits. And I'm sure, if you're working in a clinical setting or if you're a health professional, you would know what clinical audits are. So you need a tool that allows you to then monitor your clinical practices, something that would allow you to compare your current practices against best practices or best practice recommendations from guidelines, and then provide some form of feedback on areas where you need improvement. So in this example of a tool, users can actually perform baseline assessment in order for them to have a good picture of the current state of practice in relation to best evidence. Because you want to know how close or how far your clinical practices are in line with best practice recommendations. And that would help you identify gaps in practice and then set targets for improvement. Again, I've taken some screenshots of that example tool that I've mentioned earlier. It also facilitates collaboration, and collaboration is very important in changing practice. So the tool, you should have a tool that allows collaboration among healthcare teams, something that allows you to share data, implementation strategies, as well as outcomes. Now that collaborative approach, that would facilitate or help consistent application of evidence-based practices, particularly if you're applying it across different wards or units within a health service, or even if you're just changing practice in a single unit or in a single ward. Now, PACES in particular helps, just like I've mentioned earlier, it helps identify gaps between current clinical practice and best available evidence. And that's really important because that becomes a stimulus for change. So you need to have a good understanding of the difference between your current practices and best practice recommendations. And that would be useful in developing action plans because that would address the gaps. So you need to have a structured platform for implementing the action plans, for monitoring progress, and then you make adjustments as needed, and then ensure that changes are being effectively integrated into practice. You also need something that would allow you to have an ongoing evaluation to ensure that whatever changes you manage to introduce are effective and then, of course, sustainable over time. So this is just really an example of a report that can be generated by a tool that then, like PACES, for example, it allows you to track the changes in practice over time, and you could see if you're able to sustain those improvements, and then they become the status quo in your health service setting. So again, in terms of methods, it's important to have cohort-based training and programmatic methods for implementation, as well as a tool that would help operationalize a theoretical framework for implementation or a model, just like what Craig said earlier. And at this stage, I want to give you an example of an evidence implementation initiative where a cohort-based training was utilized, as well as the use of a tool that helps them, that guided them through the process of implementation. So that project was actually published recently in PMC Nursing, and you can see the title, and this is freely available. So if you want to know more about this project, you can access it. So that's the title of the implementation project that was conducted. And as you can see on the slide, it was conducted across 74 hospitals in China. So that's a multi-site evidence implementation project. And this is a perfect example of a cohort-based training program that actually integrated the 7-phase model that Craig showed you earlier. So the project aimed to standardize chemotherapy assessments across the hospitals in China to improve patient safety and also minimize adverse reactions from chemotherapy. It involved a baseline audit because obviously they wanted to know current practices before they even implemented any solutions, and they then did a post-audit. So this study, it exemplifies how a structured cohort-based implementation program, and then also supported by tools, can bridge the gap between research and healthcare services, and it actually led to significant improvements in clinical outcomes. So again, what are the methods that they've applied in that project? So I mentioned earlier, it's a multi-site evidence implementation project. It involved a baseline audit to know what their current practices are, and then they did 2 follow-up audits to check whether after implementing solutions, whether change in practices related to pre-chemotherapy assessments happened over time. So they started that project with an intensive training, intensive workshops about the different theories, models, and frameworks for implementation. They also thought about clinical leadership, also clinical audits. And then they did every individual hospital that participated in that project develop their action plan, but they worked collaboratively across those different sites. They in fact established an online platform where they could communicate with each other, share resources, share their experiences and learnings across the different hospitals. Of course, even though they're all in a single country, every hospital would have their own specific context. So some of the strategies and the learnings could be applied across the different sites, but they also had to apply context-specific or hospital-specific strategies in addition. So they did live online broadcasts as well, so that all participating hospitals then could come together. So what did they find after conducting the initial implementation? So, well, I have to say, of the initial 74 hospitals, 70 completed the complete cycle of the pre and 2 follow-up audits. And there were significant improvements in terms of compliance. What do I mean by compliance with this? So there were significant improvements in compliance to best practices in pre-chemotherapy assessment. And aside from improving practices so that they're more aligned with best practices, they also evaluated patient satisfaction and chemotherapy safety, which were also improved following the implementation of solutions, and that was sustained. So they did after 3 months and then after 9 months. So I've just put here one of their tables that show improvements in compliance, and this is across all of the hospitals. And you would see that from their baseline audit, there have been significant improvements during the first audit, and that was 3 months after the implementation period. And then they did another follow-up, and you could see there further improvements. But aside from improved compliance to best practices, it's also important to recognize here some more implementation findings. So they've reported on barriers and the strategies that they've implemented. And this is actually crucial for a number of reasons. One is for understanding challenges. So by identifying barriers, that provides insights into the factors that hinder successful implementation of evidence-based practices in pre-chemotherapy assessment. So understanding those challenges would help in recognizing, the complexities or the complexities involved in translating research into practice. That's also very important in terms of tailoring strategies or tailoring solutions. So by reporting on the strategies used to address the barriers that they've identified, the study offers, practical solutions that can then be adopted or replicated in other settings. Now, that information is valuable for other organizations who might want to do similar projects or facing the same challenges. Improving implementation processes. So documenting both the barriers and strategies contributes to a more comprehensive evaluation of the implementation process. So it helps not only in assessing what was achieved, but also how obstacles were overcome that could lead to more sustainable practice changes. Informing future projects. So their findings on barriers and strategies, they provide valuable lessons for future implementation projects. So that would be helpful in guiding the design and execution of similar programs, and then highlight potential issues and which approaches were successful. And then, of course, it enhances replicability. So sharing details about barriers and strategies could enhance the replicability of that project. So other institutions or regions can learn from the experiences of this study. We now move on to the third component of the 3M. So we've spoken about the importance of having a model, methods, and now we move on to the last component of the 3Ms, which are mechanisms of action. So by mechanisms of action, we focus on pathways that can be used so that implementation programs can sustain or can continuously produce their effects. Now, we have, in our institute, we have developed this partnership program. So it's called the JBI endorsement program. When we developed this program, it was really an award or a recognition that we grant to those health organizations that demonstrate commitment to evidence-based practices and continuous quality improvement. So that's well and good. It's an award, it's a recognition, but it's more than just that. It's more than just a recognition. But what it is it's a strategic partnership between health organizations who are committed to sustainable implementation of evidence-based practice and academic researchers who work in the implementation science space. And that's a very important partnership. So by endorsing organizations, like with us, it's the JBI endorsement, by endorsing organizations that have integrated the framework, you remember the 7-phase model that you can see on the slide, into their quality improvement initiatives, we establish these institutions as living laboratories for implementation. And that unique relationship allows us to provide continuous support to the health organization to ensure that evidence-based interventions are not only adopted, but also sustained over time. So through that partnership, the organization, and of course the health professionals within that organization, have that opportunity to collaborate closely with implementation scientists and researchers. And that's really a very critical partnership. And that collaboration fosters an environment where there is ongoing learning, there's adaptation and improvement as part of the organization's culture. Okay. So with that program, we have 3 standards. We call them the 3 Cs, and they represent commitment to evidence-based healthcare, continuous quality improvement, and capacity building, which are really very important in making sure that what the healthcare service delivery is of high quality and safe to their clients. Now, those standards represent the minimum acceptable requirements for quality and safety in healthcare. And within each standard, we have set criteria on which to assess the healthcare organization and if they have the structures and the systems in place to ensure that standards of quality are met. Aside from the partnership and building a culture of innovation within the health organization, there are some benefits associated with JBI endorsement as well, and you can see them on the slide, and I won't go through each of them because I really want to highlight the organizational impact that that partnership can bring. So one is around advancing knowledge. So the program fosters a culture of continuous learning. So it's about having a system, a continuous quality improvement system in place that integrates a model, different methods for supporting the clinicians, and the use of tools, and also ensuring sustainable programs. So it fosters a culture of continuous learning and knowledge advancement. JBI endorsed organizations benefit also from a structured approach to capacity building. So through tailored education and training programs supported by tools and resources, those organizations can enhance their staff skills and competencies in implementing and sustaining evidence-based practice changes. The program also emphasizes active dissemination and transfer of knowledge that would help ensure that evidence is not just available, but it's also actively utilized in decision making. Health system impact. So by adopting a framework, okay, or a model, and being part of this program, organizations can achieve measurable health impacts. So that could include, improved patient safety, reduced variability in care, and enhanced efficiency in service delivery. And then lastly, of course, collaboration and partnership. Those organizations that have been endorsed are part of an exclusive network of living laboratories, providing opportunities for collaboration and partnership. So by working together with the different endorsed organizations, they can share insights, they can share their strategies and best practices. So you're actually creating a collaborative environment that then drives innovation and continuous improvement across the health system. So in summary, the endorsement program, it recognizes an organization's commitment to evidence-based practice, but it also empowers health organizations to advance knowledge, to build capacity, make informed decisions, achieve health system impacts, and then collaborate with other leading healthcare institutions. Now I'm going to hand over again to Craig, so he could then integrate all of those 3 M's. Craig, over to you.
So thank you very much, Lucy, and it's really great to hear your thoughts about 3 M's and how we can move to a more integrated model. So we're wrapping up today's JBI Live for August 2024 with you. And one of the things we're keen to do is just do a really brief recap, which is just to go, where did we start? We started by understanding and accepting that there's a bit of a gap, a bit of a problem between the connectedness of science to practice and how and where we want that to work for us. And how do we then move on from there into an approach that helps to actually better integrate to create communities and cultures where we can have closed loop processes in an open system. And earlier we looked at the evidence that integration in traditional settings is also not strong and not a strong contributor. So we have to think about cohort-based approaches, such as targeted education and training that draw on things like the practical application of clinical evidence, which is the PACES software and other tools and resources that help us to mobilize evidence in organic organizational ways, because that's how clinicians and practitioners work. They work in organic organizational ways. So what Lucy has walked us through really is the nature and accessibility of particular resources and pathways that will assist us to close the loop, building at the same time leadership and governance by drawing on evidence-based solutions. So we want to, I guess, give you the opportunity to ask questions, either here in this session or or online or on Twitter, or to contact us directly and talk about what you've heard today, because we'd be really interested in your thoughts and feedback. So thank you very much for your time.